Hey, so it's back, exam 2 for my students, and so this is just a brief review of the information that was provided for them for influenza, pneumonia, otitis media, conjunctivitis, tonsillitis, and pertussis. So let's get started. So let's talk influenza. So who needs the vaccine? Actually, those with chronic medical conditions, people with asthma, any kind of COPD, other chronic medical conditions are at a high risk of getting very, very ill with influenza. History of pneumonia, anybody over the age of 50, pregnant women, and healthcare providers, because we're right in there with the sick of the sick and can definitely get sick or have it and spread it before we realize it and make other sick folks sicker, and we don't want to do that. But just remember that the flu shot should be given to anyone or provided for anyone who would like to take it over the age of 6 months. Remember your signs and symptoms of flu. Sudden onset of fever and chills. You're going to feel just, feverish, headachy, fatigue, dry throat, raw throat, hard to swallow, photophobia, right? Flushed face due to fever. So these are some of the signs and symptoms of flu that we see. They're classic signs. And one of the things is that just remember that raw throat, hard to swallow, things like that. So they need fluids because of the fever. And so we can do popsicles, clear liquids, warm chicken noodle soup or chicken soup, some type of soup, something to help soothe the back of the throat, nothing hard or hard to swallow, because it can really cause pain and discomfort, and we don't want that. Tamiflu, also known as Tamifir, it takes me a minute, is given within 48 hours of onset of symptoms, taken for 5 days. This is an antiviral. When it came out, we were so excited, but as soon as you start to have the symptom of the flu, you have 48 hours to start the antiviral. It's not going to stop the flu, but what it's going to do is help hopefully lessen the symptoms and help you to get over it a little more quickly. This is a PO form of medication, so you have to take it. You take it for 5 days and go from there. Relenza disc inhaler is another antiviral, but it is used for influenza A and B. It is an over-the-counter medication, just FYI, which I thought was quite interesting. It's an inhaler that's inhaled 2 times a day for 5 days, and it started within the 48 hours of onset of symptoms also. So both of those drugs are antivirals. One is specific for influenza A and B. Tamiflu we give for flu. It's specific for flu also, but we also can give it for some other viruses. They'll start it, and it just has to be given within 48 hours of onset of symptoms. One is inhaler, one is PO, and they're both for 5 days. Pneumonia, so let's get started. Ciprofloxacin is an antibiotic used for hospital and ventilator-acquired pneumonias. I went ahead and put here, you see HAP/VAP. This is what stands for hospital-acquired pneumonia, ventilator-acquired pneumonia. It is used against Pseudomonas, so that's kind of interesting to know. It's a big boy antibiotic. We use it a lot for UTIs also. Big side effect is photosensitivity, so you know. Aminoglycoside antibiotics, gentamicin, tobramycin. A lot of people have heard of Gent or gentamicin, but tobramycin is another one that's used. Another big boys is what I call them. These are broad spectrum antibiotics, but they're nephrotoxic. So when you hear nephrotoxic, it means it's going to be toxic to the kidney. So one of the things we want to do is, first of all, look at diagnosis. Do these patients have a diagnosis of a renal issue? If that's the case, they really don't need to be getting these antibiotics, because it's only going to cause more problems to the kidney. The other thing we want to do is, if the patient's going to take these medicines, We want to check a baseline BUN and creatinine because we want to know what the function of the kidney is. Then as they're taking it, we would want to check on that or draw other labs as we go on, making sure this hasn't become nephrotoxic to the patient and the creatinine goes up and the kidney starts to be hurt by this medication. So remember that the aminoglycoside antibiotics, gentamicin, tobramycin, are nephrotoxic. And there are other drugs out there. I know I lectured last week, and some of the opioids are nephrotoxic, and I thought that was quite interesting. So we need to be very careful, and patients and people need to realize this, is you'll shut your kidneys down if you're not careful. Cephalosporins, also Maxipine and Keflex, these are antibiotics. They're given for pneumonia, but always asking the patient if they have allergies, because where cephalosporins live is they can cross over into the penicillin world. Not that they're penicillins, but just as generations of medications have been formed, there is a connection through it. Not everybody, as a matter of fact, I looked it up, I think it's like less than 1%, but there is a percentage and we can see it. Matter of fact, any medication you're giving, I always tell my students, when you go in, ask name, date of birth, look at that armband, do your identifiers, and then I always ask before giving the medicine, do you have any allergies? And it doesn't matter, I can work with a patient 2 days in a row, 12-hour shifts, and on that second day at 6 p.m., I go to give a medicine and I'll say, do you have any allergies? For the 50th million time, and that patient will go, no, and then the family member's in there and they'll go, you remember that's the medicine you took 5 years ago and you had hives all over your body and an itchy throat, you know, and so they'll identify this allergy. So it's so important just to keep asking and asking, because sometimes people forget or people don't realize, and so sometimes loved ones can help. So anyway, always asking. If you're when in doubt about any medicine, call the pharmacy, ask if it's okay if they have a penicillin allergy, if they get this, and then also ask the physician. You can call your physician MD and clarify, you know, they have this antibiotic ordered, they have a penicillin allergy, do you want me to give the cephalosporin? So last but not least with pneumonia, always remember your ABCs. Airway, breathing, circulation. Airway, do they have an open airway? Are they able to take a breath? Breathing, are they breathing? And circulation, do they have a pulse? Now, as nurses, it's as simple as that, but it gets complex. So the complexity of it is we've got to look at our data. We've got to look at our vital signs. We've got to look at our oxygen saturation. We need to look at our patient. We need to see what's going on and do what is needed to continue homeostasis or life, correct? And so if it's a volume issue, we're going to give fluid. If it's an oxygenation issue, we're going to give oxygen, and whatever. We'll correct the situation based on what we need to do. Let's get started with otitis media. Signs and symptoms: pulling of the ear, high fever greater than 104, 104 or greater, vomiting, diarrhea, febrile seizures. Those high fevers can cause kids to have seizures, so it's so important that we treat the fever. We need to give them an antipyretic. Other ways, you want to give the medicine to bring those high fevers down, but we can also do tepid baths. But I will tell you, the old wives' tale of using alcohol and wiping down, no more. That can cause more problems. You can actually even have the child seize if not careful because you're cooling them too quickly. So we don't do that anymore. The tympanic membrane can appear bulging, cloudy, and irritated red with the middle ear infection. So we have that middle ear infection. That's what if we're looking with our otoscope down, we're looking, we can see this. Be careful if using the otoscope. If you go in too far, you can puncture that tympanic membrane with the tip. So be very careful and just slide yourself in carefully, looking the whole time so that you don't get too close to the eardrum and create more of a problem by rupturing the drum. Normal eardrums are pearly gray, translucent, shiny, and there's some movement in them, and the fluid will move some. You might see that when examining. A meringotomy is the tiny incision in the ear where the tubes are placed. So these children have had ear infection after ear infection after ear infection. They go in for the surgery, they make this little tiny incision, the tube will go in and stay in. They don't go back in and remove them. They fall out on their own 6 to 18 months after placement. Now this is the thing that can happen. Tubes can fall out before they're better or before the time that is needed for them to come out. So unfortunately, kids sometimes have to go back and get tubes placed again. But they're in and can stay in from 6 to 18 months. Some books say 6 to 12. NCLEX stuff can say 6 to 12. We have a book here that says 6 to 18. So I just put in that so you know. 6 months to a year and a half, the tubes will fall out on their own. So there's no need to worry. Always remember to pull down and back on a child under 3 years of age. If I'm doing eardrops, it's down and back. If it's an adult, it's back and up, right? Because we're straightening out that canal so that we can get the drop down in there. The other thing is remember to have them lay on their side and allow that drop to stay in the ear as usually up to 10 minutes. If you have a child and that's almost impossible to do, or if you're an adult and you're in a hurry and you're doing ear drops, you can take a cotton ball and drop the medicine at the tip of the cotton ball, a couple drops, and then place it in the ear so it doesn't wick the medicine out. It'll hold the medicine in so that it does what it needs to do. Tonsillitis, pertussis, and conjunctivitis. That's what we're going to just cover really quickly. Pertussis is also known as whooping cough. It's highly contagious respiratory infection passed through airborne droplets, saliva, skin-to-skin contact. So anybody with whooping cough, if they happen to be hospitalized, would need to be on airborne and contact precautions. It's highly infectious, so we need to be contagious, so we need to be very careful if anybody comes up with pertussis. There are vaccines for that. We hear the whoop and the sound when the patient inhales after a severe hacking cough. So it's a whooping sound, and that's how it got the name or nickname of whooping cough. Signs and symptoms. We'll have a low-grade fever, runny nose, and that hacky, barky cough with a whoop upon inhalation. The thing is people go, oh, it's a cold. Well, it's more than a cold because it'll resolve on its own for a child that's older, that is healthy, but where we see it to be detrimental is for infants. It can be deadly to infants. So we don't want to spread it to infants. We don't want infants to get it. And I think, honestly, in history, it was an issue. It was going around and killing babies, unfortunately. So tonsillitis, pertussis, and conjunctivitis. We've talked about that. We've talked about compresses. Go back through your notes, look at how to give eye drops, how to put eye ointment in. We don't put it directly on the eye. It needs to be, you pull down and we go along easy, always starting inward, going out if we're doing ointment, not touching the eye, not touching the outer part of the eye. Always careful with the cap. If we're doing an ointment, don't be laying it, don't be putting it all up in your hand. Be very careful, keep it as clean as possible, then you put it back on, because we don't want to introduce anything to the other eye or back into the eye that we're trying to help. We have the tonsillitis piece. There was more information given in the actual video. You can go back and listen, but this is just to give a brief overview and review for the test that's coming up for my students. I think I have 12 questions total. So I hope this helps, and I wish you the best.